Hello, class. Welcome to chapter 12. We're going to be talking about medical conditions involving neurological disorders. This chapter begins on page 62, and that's also where you will find your key terms of absence seizure, congenital, electroencephalogram, generalized seizure, idiopathic, postictal, psychotherapeutic drugs, seizure, status epilepticus, and tonic-clonic seizure. Lots of tongue twisters in there. So make sure that you know those key terms that are on page 62. Of course, those are always important, right? Key terms help us, those vocabulary words, so that we can better converse with our patients, so we better understand things, and it just makes us more well-rounded healthcare providers. So we're going to be going over a few key medical conditions in chapter 12. Make sure that you read the chapter as a whole and that you also do any of your additional resource readings. And I apologize if you hear my dogs barking on this recording, as they are very disruptive, but very cute at the same time, if you could see them. So the first medical condition we're going to talk about is epilepsy. And this is really one of the main conditions in this chapter that can prevent like a true medical emergency, the possibility of that. So when we're talking about epilepsy, this is in relation to seizures. And one thing to remember is that a seizure is not a disease, but rather it is a sign of a disease. But it nonetheless is something that we take seriously. And unfortunately, sometimes there is not an explanation or an understanding of why an individual experiences epilepsy or seizures. Now, this is an idiopathic or primary epilepsy, and this is often in cases in younger individuals, and it is not always understood why someone experiences these, which can be extremely frustrating. It can also make it more difficult to treat them too if we don't know where they come from. Now, acquired epilepsy or secondary epilepsy is usually the result of something, right? It's caused by something like fever, head injury, brain tumor, drug toxicity, cerebral palsy. So these are examples of things that can cause epilepsy, which then can also cause seizures. I've had a few patients that have cerebral palsy in the past. Thankfully, never had any issue with like seizure related emergencies. I do remember as a child growing up, there was a woman in my church growing up that had epilepsy and had brain damage from when she was a very young child, and she had a fever. So hers would be an acquired epilepsy because she had been very ill, and that had caused some issues and brain damage for her when she was a child. So those are the two different categories. So that's something we can always ask a patient, right? If they have epilepsy, we're going to ask them what kind of seizures do they experience? And we'll go over a few of those other ones. So now, in relation to like acquired and idiopathic or primary epilepsy, we also have types of seizures, and there are some different categories. So you have two types. You either have a focal or you have a generalized type of seizure. So focal seizures can have a simple focus of seizures, and they're confined to a small area of the brain. They can be like tingling or sensations in the arms, fingers, and foot. You can have a perceiving of bad odor, seeing flashing lights, or speaking unintelligibly while remaining conscious. This seizure does not usually progress into a generalized seizure, and we will talk more about those. But the discussion on this is important, right? So that we understand if maybe our patient experiences some of those things. Now, a complex focal seizure can involve one side of the brain or extend to both lobes of the brain. And these can be characterized by automatic behavior in which the client remains conscious, but they can have some impairment, um, and there is no memory of the seizure. Um, so they may sit motionless, or behaves in strange or repetitive or inappropriate ways, and can progress to a convulsive seizure if the stimulation crosses to involve both lobes of the brain. They may lose their ability to speak and things like that, right? So that's your focal, simple and complex types of epilepsy. Now, your generalized seizures are ones that I will say are, I feel like, the terms that we hear more when it comes to seizures, like a tonic-clonic seizure, which used to be referred to as a grand mal. And so those are bigger seizures. They can include things like crying out, stiffening of the muscles, becoming unconscious and falling to the ground, loss of urinary and bowel control, and having muscle spasms or thrashing movements of the limbs. So these are much more noticeable and can be more problematic, the tonic-clonic seizures. During the tonic phase, their breathing may decrease or stop. They may become blue. They have that cyanotic lips, nail beds, and face. And then breathing typically returns during the clonic phase, but can be irregular, right? So the tonic phase is the first phase, and the clonic phase is the second phase. And these ones can be definitely the most scary for us as providers if someone experiences those. And then we will talk about the status epilepticus. There are some characteristics of seizure episodes that require 911. And we will go over those in a little bit. I think a couple slides after this. So after the tonic-clonic seizures, we also have myoclonic seizures. This is a generalized seizure again, and it's usually rapid and brief contraction of body muscles, usually occurring simultaneously on both sides of the body. So the patient may experience like a sudden jerk or clumsiness. This type doesn't usually pose an emergency situation. Although, like, when you're seeing the patient, if they have this sudden jerking, could potentially be a risk for like us to cause a laceration in their mouth or something like that. So it's important to know if patients experience this, right? So that we also know what's going on if that happens. So then we have absence seizures, which used to be called petit mal, and they're characterized by a brief impairment of consciousness and jerking, staring, or spastic muscle movements, such as fluttering eyelids, which begin and end abruptly. So they only last a few seconds. So you can see where like the previous names of these kind of came in place, right? It was a petit mal because it was a smaller seizure. The grand mal or the tonic-clonic seizures were much larger and all-encompassing. So often with an absent seizure, they may have alterations in sensation and impaired consciousness, but there isn't the falling to the floor. But there are usually no warning or no after effects of this type of seizure. They typically don't pose a risk to medical emergencies, and they're less concerning for us in a healthcare setting. Then we also have the atonic generalized seizures, right? Generalized again, we're still on that bottom little kind of area of the slide. And this can produce an abrupt loss of muscle tone. So instead of that like contraction, you have the muscle tone loss. And it can lead to like a head dropping or loss of posture or a sudden collapse. The difficult thing with this outside of healthcare is that it's often resistant to drug therapy. And so it can pose a risk for recurrent surgeries during oral care. So, an atonic generalized epilepsy can be problematic because it's harder to control. So, again, it's important as healthcare providers to know, right? So, what if somebody tells you that they do suffer with seizures? You're going to want to know when their last seizure was, what type of seizures they have. Um, do you have you taken your medication? Like what kind of medication, right? Is something that we'll follow up with, and then we can ask, oh, did you take that today? Um, it's good to know like if patients have signs before their seizures because they may be able to give you a warning. And in my experience, a lot of times patients will let you know. Like they don't want you to be caught off guard because that puts them at risk. So they will share these types of things with you while you're working on them. And then it can be important to ask them if they have had, there's my dog, he's just being bipolar, if they have had a seizure during dental treatment before, kind of if there are patterns for them so that we can know if there are certain things that we should avoid. So a good example for this is I have had not a lot of experience with epilepsy, thankfully, but I have had a patient that had, she did suffer with seizures, and she'd never had one during dental appointments, but she did tend to have them afterwards. So that was more something for us to, of course, keep an eye on her while we were caring for her, but then also, we made sure that we did a follow up with her to see how she was doing after her appointments, and sometimes even like the day of and the next day, just to make sure that we're providing really excellent, well rounded, holistic care for our patient, right? You don't want to just send them off and be like, well, good luck, have a great day, if they've shared with you that they've had issues. And she did experience a small seizure after she had some fillings done once. And so one thing that we began with, thankfully she didn't have to have oral treatment done very often, but we started just kind of trying to experiment with different types of anesthetic whenever we'd see her, and we made sure we documented that to see like if there was a certain kind that her body tolerated better. Last I knew, I don't think we had figured anything out, but it was something that we were trying to work with her to see if it could work. Over the course of time, when I saw her as a patient, she did change her medications after she had her first child. The medication she'd been taking for a while just didn't work as well anymore. So she was very on top of her general health. And it was nice because I was able to have good conversations with her. And again, I talked to her and I asked her questions. It's always great ways to, one, create a good relationship with your patient. It improves your knowledge too. And also it helps prevent medical emergencies, which of course, like I always say, is our main goal, preventing medical emergencies. So some of these scenarios we talk about, it doesn't always feel like, it's like, well, why are we talking about this? This doesn't have to do with a medical emergency specifically, but we're learning and we're growing and we're expanding our knowledge and our skills and our ability to critically think so that we can avoid medical emergencies, right? Even just random things like cutting a patient or cutting ourselves if they experience something like a seizure. So, what are some treatment implications for a patient that has epilepsy, right? You're talking to your patient, they tell you that they've had seizures and epilepsy in the past. You may delay treatment if a recent seizure has occurred, especially if maybe it was really serious one. Again, you're going to talk with your patient, talk with them, ask them about their healthcare provider, and you may contact their healthcare provider too, especially if this is maybe a seizure that they haven't had a seizure in a really long time and they did have one recently, that may be a reason that you delay some elective oral care. But talk with your patient and find out what their comfort level is too, and the patterns and the experiences that they've had with their epilepsy and how they have taken care of them in the past. And if you need to, call their healthcare provider. So if their seizures are controlled and their epilepsy is controlled, then we can proceed with oral care. And of course, again, we're having those great conversations with our patients. So one of the other things too that's an important thing to know are some side effects of epilepsy, in particular the medications that they take. Dilantin is a common one, and epileptic medications can very commonly cause overgrowth of gingival tissue, and so also can cause xerostomia, but the overgrowth of gingival tissue can be difficult to manage. It can be manageable though, and so it's really important to, work with your patient that is on epileptic medications about a strict plaque control, brushing and flossing and toothpicks and interproximal aids and anything that makes life easier for them, so that we aren't adding to that overgrowth of gingival tissue. And even if we have the overgrowth, that it's not because of additional inflammation, that maybe it's just because of the medication. Because chronic inflammation has its own whole set of issues that can be problematic for our long-term health and longevity of life. So management of a tonic-clonic seizure, right? The old term grand mal seizure in the dental office. So we talked about some of those symptoms already. And so if we're noticing those, and that's where it can be good to know if your patient is able to let you know. Sometimes they will have a sense, they know that one is coming. And then that way you can help get them into a safe position for whenever they experience the seizure, because we don't want them to cause themselves harm. So of course, if a patient is experiencing a tonic-clonic seizure or any of the other smaller ones, we're going to remove our instruments from their mouth. We don't want them to get hurt. We also don't want ourselves to get hurt. We're going to move the client to the floor prior to onset, if possible. Again, communication with our patient when it's able is important. And then if we cannot get them to the floor, we're going to place the chair in a nice supine position as if they were laying on the floor. We can turn the client to their side if we need to. Again, remove any other equipment that may be nearby that could cause them harm. And then passive restraint only as needed, especially if they're in our dental chair. You may use some passive restraint more to just make sure that they stay on the chair. But of course, we also want to maintain our safety too. And then, of course, we're going to make sure that we're maintaining the open airway, especially whenever they're in that clonic phase, right? The tonic is more of some of the like spasms and jerking and thrashing of limbs, and the clonic phase often is a little more quiet. And so we're going to want to make sure that they're breathing again, that they maintain that open airway. Now, just because a patient experiences an epileptic seizure in the chair does not warrant the need to always call 911. However, there are specific factors that can play into that where we would need to call 911. So that's status epilepticus. And if any of these occur, then we do need to call 911 or react appropriately, right? So if a patient has multiple seizures over more than 5 minutes without regaining consciousness between, they're like cycling through their seizures and they are not waking up in between them, then we need to call 911. If they're having breathing difficulties after the seizure has kind of finished and they are having difficulty breathing, we're going to want to call 911. If they have persistent confusion or unconsciousness, they may not be having a seizure again, but they're not there, they're unconscious, or they're very confused for more than 5 minutes after a seizure, we're going to want to call 911. If they sustain injuries during an epileptic seizure, then we'll want to call 911. And of course, if this is a first seizure that someone has experienced and they have no past history of seizures, then we want to call 911. And then if a pregnant patient or a diabetic patient experiences a seizure, then we're going to want to call 911. So, like I said, a tonic-clonic seizure or any of the other types of seizures does not warrant a 911 call always. But if any of these 6 items occur, then yes, we want to call 911, either during or following, the main part of the emergency. So these are important to keep in mind if those are experienced. So what about some mental health disorders, right? So some of these next topics we'll talk about are not things that can create those like medical emergency scenarios like we were just talking about with a tonic-clonic seizure. But they are important, right? Like I said before, we're always looking and evaluating and assessing so that we can avoid any type of a medical emergency or a negative scenario in the dental office. So, mental health disorders, of course, can cross many, many lines, but a few examples of them are depression, Alzheimer's disease, bipolar disorder, schizophrenia, psychosis, and Down syndrome. Now, with a lot of these, xerostomia can occur from medications that patients may take. And then sometimes you can have behavioral challenges with some of these mental health disorders. And so it's important for us to maintain a good composure, have a good trust and communication with our patient, change the topic following inappropriate comments, and then encourage improved oral care for our patients, of course. I feel like that's always like a given, but we definitely want to help them. And we may, in encouraging improved oral care, we may have to, change up the way care is done or get creative in reminders and things like that to help them remember or help them utilize new tools if maybe some of their mental health struggles make it harder for them in a dexterity way. Parkinson's disease is also involved with neurological disorders. And this creates like a reduced dopamine production in the brain. It's common in older adults. And some of the signs and symptoms can be tremors of the face and hands, which can, of course, make it harder to do those daily oral health routines. Pill rolling in the fingers, stiffness, a shuffling gait, loss of facial expression, impairment of memory, mood and sleep disturbances, and orthostatic hypotension, so that risk for passing out in the dental chair. And again, like Parkinson's disease itself is not like a medical emergency, but we can have some struggles or challenges in the dental practice, especially falling can be a concern. So we're just going to adjust and adapt the best that we can for our patients so that we can provide them a good holistic oral health care and then also prevent any types of injuries to themselves while they're there, and then helping them adjust so that they can find better ways to improve and maintain their oral health so that they have less issues when they're coming in to see us. So this slide talks a little bit about what I had mentioned before, right? That you can have struggles with oral hygiene. They also can experience things like burning mouth syndrome, excessive saliva and drooling, swallowing difficulties, fungal infections, and xerostomia. So when they're in our chair, we're going to evaluate their disease status, whether it's the Parkinson's disease and their oral health. We're going to assist them and we're going to help them move slowly to prevent any fainting, provide written instructions, and maybe, help them demonstrate some of their oral hygiene procedures so that we can help them find better solutions. We may need to be aware of timing of appointments. We want to pick a good time of day for them. And electric toothbrushes can be good too. The other thing to note with a lot of these, like Parkinson's disease, and really lots of neurological disorders, is that clients may have a caretaker who could be a family member, or they may be like a nurse or a CNA, or somebody that lives with them that helps care for them. So you may be having conversations with that caretaker, be it a family member or not. And so we need to have that good communication and trusting relationship with that individual too. Especially with like patients that have neurological memory loss, in like Alzheimer's disease, or like a patient with Down syndrome, they may not be able to remember things as well that you tell them. It's important to communicate, and that's where like giving written instructions can be helpful. But then we also want to still respect and allow our patients to have some of that self-autonomy too. So it's finding that balance, right? So again, we can ask permission of our patient too if they have a caretaker. You can say, is it okay if I share what we talked about with, such and such, whoever's with them? Or asking them, would you prefer to be in the room yourself, or would your caretaker is welcome to come with us? So that you are giving them the option, you're not making assumptions on their behalf. Which again, helps create a good relationship and helps with management of clients and self-esteem and all of those good things. So Alzheimer's, of course, is an example of individuals that will probably have a caretaker depending on the progression of the disease. And it can, if any of you have experienced Alzheimer's disease with someone that it's a hard disease. It definitely is progressive. And it really destroys the abilities for memory and reason and learning, making judgments, communication, carrying out daily activities. So especially if a caregiver is like someone's partner, putting things in writing can be helpful for them too, because they're not only trying to care for their own health, but they're trying to care for the health of another adult. And it is very taxing emotionally and spiritually. It can be really difficult as a caretaker, especially whenever they are your loved one, your husband or wife or partner in life. So communicating again with them is important. And also maybe putting things in writing for them so that they're not having to remember everything that you talked about, is if there are new recommendations or suggestions that you've given them to help care for the individual that they are caring for that has Alzheimer's or Parkinson's or any of those. So again, dexterity can be a struggle with Alzheimer's. We want to make sure that we're providing simple explanations. You smile and use direct eye contact, right? This is true with any patient, but it is important, especially if we do have patients that are struggling with other diseases and disorders, that we're not making them feel less than. And then we want to make sure that we have consent for issues too, right? For an Alzheimer's disease patient, anyone that's having any types of memory or making judgments, if those abilities are destroyed or just lacking, we want to make sure that we're not just getting consent from them always for care, but from their primary caregiver too. So special needs in general for patients, right, can fall into a few of these categories that we've talked about already. But some of the challenges for them can just be limited access to care. They may require hospitalization for certain care that they need. Patient positioning may be different. Communication can be challenging. And then we can have some of those behavior challenges. I've been fortunate. I worked in an office that I can't remember the name of the organization, but we saw quite a few like special needs patients at an office, and they were always really great. But it was challenging. You know, each patient had their own things. They usually had a care provider, especially some of them. They just because of some of their challenges and struggles, they sometimes said inappropriate things or did inappropriate things. I had one patient once, I remember we were always told that he was not to be like in a room alone with us, because he would say inappropriate things if his caretakers weren't there, because he knew he could like try to get away with them. And I don't know what happened, but for some reason, like maybe his caretaker, she just had to step out to the bathroom or something. But it was just me. I was like, oh, we'll be fine. Like I'd seen him a handful of times, no big deal. And as soon as she left and I turned around, he slapped me on the butt. And so I had to get after him, and then her and I had to talk about it afterwards, and she felt horrible. And I knew that it was, it was innocence, but we made sure that no one was ever alone with him. But that was just an example of some behavior challenges that you may experience. Now, is that okay to have something like that happen? No. And him and I talked about it, and then his caretaker talked about it, and her and I talked about it and had a plan. We created a better management plan for the next time he came in, so that we made sure that no one was put in that precarious situation again. But I've seen just lots of wonderful patients through that program, and I miss seeing them, especially because we got to provide care to patients that a lot of times didn't have access to the care. And on a personal kind of selfish side, it made you feel good that you were able to, be there for somebody in those ways. But again, so some of those management things, right? And is that communication with informed consent with the patient and the care provider. And a lot of times the care providers in some of those scenarios, we didn't just need approval from them, but we may not, if we had to do treatment that was different than what was planned, we would have to wait and get approval from like a family member who was kind of managed the finances and the decisions and medical care for a patient. So it can just increase your need for communication and conversations with people. You may have to have those conversations with multiple people before that you get that approval, right? But informed consent is a form of medical emergency like management, because again, we're assessing and we're taking in all the information that we're gathering through forms and conversations, and making, the ethical and right moral choices with our patients. And sometimes that's with multiple people involved in their health. So a couple of things in this chapter that we didn't go into great depth was like sleep apnea and insomnia and narcolepsy. So I do recommend that you read those, right? Those are not scenarios that necessarily create issues in the dental office. Sleep apnea is something that is becoming more common in dental health care and oral health, and diagnosing and referring patients, um, creating appliances that help with snoring and sleep apnea issues. But it's not something that usually is something we have to like address in a management or adaptation of appointments type of scenario. So you'll learn more about that in other classes. But of course, make sure that you complete your flow chart and read your chapter 12 and other resources that have been given to you and recommended, so that you are ready to go for, we're coming up on that last exam.